arteritis. So in this tune, I like to call upon Dr. Soumyava Basu, who is from LBPI Hyderabad, uveitis services, and as well as the retinal uveitis services. He would be talking on retinal vasculitis, non-infectious versus infectious, how to distinguish. Soumyava, please.
Thank you, sir. Audible? Is that audible? Yeah. So thank you very much. I think there is some mistake with the Soum. The wrong Soum is there. Soumshila is not even here.
Something is not there. Either.
I could take care of that as well.
Soumyava Basu.
So while the slide is being put up, thank you, sir, for including me in this IC, and all of you for spending your post-lunch session here and reaching this hall without getting lost anywhere else.
No.
It's come.
Isolated retinal vasculitis still accounts for almost 10% of all uveitis, and besides this, retinal vasculitis is associated with majority of posterior and panuveitis, so it's very, very common. Then what makes it different from systemic vasculitis? And here the main difference is that unlike systemic vasculitis, which is based on a histopathological diagnosis, here we do not have one, but we have the advantage of direct visualization of the vasculitis process. We see how it evolves and how it resolves in response to treatment. Then the other difference from systemic vasculitis is that it's very commonly associated with infection and with systemic disease, while it is rarely associated with systemic vasculitis such as the ANCA-associated vasculitis. This is a very important concept I would like the audience to take from here, because very often when we see a retinal vasculitis, we are very tempted to investigate for systemic vasculitis. That is not the case. On the other hand, retinal vasculitis is associated with infection more commonly and with systemic disease more commonly. So in this talk, we are going to discuss how does infectious retinal vasculitis manifest, and when it is less likely to be infectious, and what are the signs of the systemic disease that can be found in association with retinal vasculitis. So this is a brief overview of how you look at a patient who comes to you with retinal vasculitis. You look at the type of vessel, whether the arteries are involved, whether it's the veins or both. The size of the vessel is always the small sized vessels in case of the retinal vessels, and the morphology of the infiltrates. Are those skip infiltrates or are those confluent infiltrates? It's very important to describe all these findings. But the part that we are going to discuss here are what are the associated ocular signs and what are the associated systemic signs that will lead you to the diagnosis of either an infectious retinal vasculitis or a systemic disease associated with a retinal vasculitis. So this is a general dictum. It's not a hard and fast rule, but to look for systemic vasculitis, for infectious retinal vasculitis, look for other signs of posterior uveitis and specifically look for any evidence of retinitis. The best example of this, I guess, would be the tubercular retinal vasculitis. Now here are the lesions that you would want to look for in cases of tubercular retinal vasculitis. This one, which I have pointed out here, is an active retinitis lesion, and the other one pointed out here is an inactive chorioretinitis lesion. By the time the scar is formed, probably the choroid is also involved. The other feature that we have recently described is the presence of this focal vascular tortuosity, which unfortunately is pretty low down in the image, not very well seen there as well. But if you see at the red-free photo, you can appreciate the tortuosity of the vessel inside this area of perivascular infiltrate. Now, these are the features we have found in a TB endemic population could be suggestive of tubercular retinal vasculitis. The third one, which can also be seen in many other forms of vasculitis, is the presence of occlusive vasculitis. Now, important to remember here that this lesion that we see here in association with the retinal vasculitis in TB is most likely an intraretinal lesion and not a choroidal lesion to start with at least. And this we have demonstrated also in histopathological section of the retina. So, what happens when we treat these patients with So what happens when we treat these patients with anti-TB therapy? You can see that this patient who presented to us with this retinitis lesion over here and dense perivascular infiltrates and neurosensitive detachment at the macula, after 4 months of anti-TB therapy alone, this one has resolved so drastically in this particular patient. May not happen in all patients, but this is what we find, clearly suggesting the infectious nature of the retinal vasculitis in this patient. However, very important to remember that not all subvascular lesions are TB. You can see these two subvascular lesions here in this picture, and you can also make out the sclerosed vessels and the perivascular infiltrates. When we do a fluorescein angiogram, you see the extensive capillary non-perfusion areas in the periphery in both eyes. Now, when we investigate this patient for tuberculosis, we find that the Montu test is negative and the quantiferon is negative. There is no history of TB contact. However, we find that the TPHA is positive and the patient is also HIV positive. We diagnose it as ocular syphilis and treat it with benzyl penicillin for ocular syphilis. Now, the other sign of posterior uveitis you want to look for are these presence of retinitis sitting next to a healed chorioretinal scar, and this, as you all know, is recurrent toxoplasma retinochoroiditis. Now, in these patients with recurrent toxoplasma retinochoroiditis, you will also see the perivascular infiltrates here, and if you go to the original 2005 Sun classification paper, you will see that there is kind of a argument about whether to call these as true retinal vasculitis or not. Now, these patients don't just have this form of perivascular infiltrates. As the lesions heal, you also get another form of perivascular infiltrate, which you see as this segmental whitening over here, which is called as Chiariles arteritis. Now, you don't need to treat this kind of vasculitis separately. You just treat the toxoplasma infection and the perivascular infiltrates resolve on their own. This is how it appears. Now, this might seem very simple. The difficult part is when the toxoplasma lesion is lying in the periphery, and unless you examine the fundus very clearly, you may be carried away by the perivascular infiltrates alone and miss the part of the toxoplasma, which is the primary infection that needs to be treated and not the vasculitis. The other type of perivascular infiltrate, and in this case it is involving mainly the arterioles, is the one that you see with acute retinal necrosis. You see the tongue-shaped area of necrosis in the supratemporal periphery. Now, again, you don't have to treat these separately, you just need to treat the viral infection in acute retinal necrosis. Now, there is one important caveat when we keep saying that any retinitis associated with retinal vasculitis has to be an infectious retinal vasculitis. And this is the caveat. This is a patient who presented to us with this area of retinal vasculitis in the supranasal quadrant in the right eye, and a large area of retinitis and perivenous infiltrates in the left eye as well. Now, when we asked this patient about history of mouth ulcers, we found that there were history of ulcers more than 3 times a year, and we also found a left eye mobile hypopyon. So this is the way we reach the diagnosis of Behçet's disease in this patient. So this is probably the only exception where a retinitis lesion associated with retinal vasculitis is a non-infectious form of retinal vasculitis. Now, I'll just run through these systemic diseases or the non-infectious forms of retinal vasculitis, which can be broadly categorized into three groups. One are the systemic diseases, and these are most commonly sarcoid or Behçet's. The eye-limited forms of retinal vasculitis, which you know is IRWAN, and the rare forms of systemic vasculitis that can be associated with retinal vasculitis, such as SLE or Takayasu, in which case it is called as occlusive vasculopathy rather than occlusive vasculitis, or very, very rarely, less than 1% of the cases where you can have an ANCA-mediated vasculitis. So this is an example of sarcoid. In the previous presentation, you saw the candle wax drippings that are associated with sarcoid retinal vasculitis, but in association for sarcoid, you want to look for these granulomatous capes, peripheral anterior synechiae, and these hypopigmented spots seen in this picture, besides looking for the organ-specific involvement, which would be mainly in the mediastinal lymph nodes apart from the skin, or in the CNS or cardiac sarcoid. This is idiopathic retinal vasculitis, aneurysms and neuroretinitis, also called as IRWAN, more common in females. You would want to look for the aneurysms at the Y-shaped bifurcations of the lesions, and these would be associated with peripheral occlusion and this area of macular exudation as seen in this patient. Very, very difficult to treat, but important to recognize the pattern of IRWAN in such patients. This is occlusive vasculopathy associated with Takayasu. You can see the extensive area of capillary non-perfusion but no perivascular infiltrates, also seen in conditions such as SLE or Suzak syndrome. So let's finish with this, this picture again. Now let's evaluate the fundus photo we have with us. What is the type of vessel? We know that it's a small vessel. It's involving mainly the veins, so it's a phlebitis. And we have both skip vasculitis, which are the area of small areas of vasculitis, and we have confluent vasculitis that you can see here. Now, when you look at the associated ocular signs, you see that there are these subvascular lesions that are pointed out by these arrows, and sectoral hemorrhages suggestive of an occlusive vasculitis. And then when you look at the associated systemic signs, you see that the Montu test is positive, there is a history of TB contact, and very, very importantly, the TPHA was negative. We should not ignore that part of the finding. And based on this, we reach the diagnosis of tubercular retinal vasculitis in this patient. So thank you for your attention, and invite all of you to the Uveitis Society of India annual meeting in Hyderabad in October this year. The early bird registration is still open. Thank you very much.
Thank you, Soumyava, for a brilliant presentation on retinal vasculitis. It's indeed a challenge many of the times to diagnose an infectious versus non-infectious uveitis, particularly tubercular retinal vasculitis and idiopathic retinal vasculitis. So you elucidated not only that, but also various types of infectious uveitis and systemic diseases associated with the